السلام عليكم. طبعا بحيي واشكر اخويا الدكتور والدكتوره اماني على دعوتي عشان اشارك في المحاضره دي في مؤتمر وحده الغدد الصماء بجامعه المنصوره. وطبعا ربنا يزيح الغمه. أشكر جميع الأعضاء العاملين في وحدة الغدد الصماء بجامعة المنصورة. My talk today is non-Pth dependent hypercalcemia. 4-month-old boy, third kid with positive consanguinity with birth weight of uh, 3 kilos. The complaint is failure to gain weight and poor activity. Patients with breastfed with refusal of feeding and hypotonia with constipation. Mother gave history of vitamin D supplementation of 1 dropper. As 1 dropper is equal about 2,000 units. Physical examination was normal and there were no stigmata, no signs of physical disease. His growth chart revealed normal height for age, but his weight had decreased by within the 3%. When hospitalized, blood tests showed high levels of post-calcium, 22 mg/dl, and parathyroid hormone level was undetectable, 5.1 gram per milli, and 125 vitamin D was high, 190 picomole per liter. Total vitamin D was 75 nanogram per mil, and the normal is 25 to 80 nanogram per mil, and serum phosphorus level was 2.3 milligram per dl, which was low. Liver, kidney, and thyroid functions were normal. Ultrasound of the kidney revealed medullary nephrocalcinosis, and his urine was found to be hypercalciuria with calcium creatinine ratio about 1.9 millimole per millimole. So we have a patient with hypercalcemia, low phosphorus, and high 125 dihydroxyvitamin D and undetectable PTH with hypercalciuria and nephrocalcinosis. When we are looking for hypercalcemia, is defined as serum calcium concentration that is greater than 2 standard deviation above normal mean. The normal is 8.5 to 10.5 milligram per dl. When we are dealing with calcium, we have to check for the blood gas, if there is the acidosis or alkalosis, and also for the adjusted calcium, which is equal total calcium minus albumin plus 4, and the calcium is milligram per dl, and the albumin is 1 gram per dl. When we are looking for calcium homeostasis, all we know that in the skin, the 7-dihydrocholesterol for ultraviolet radiation will be transferred to pre-vitamin D, and this pre-vitamin D we're having 25 hydroxylation in the liver to form 25 hydroxyvitamin D calcidol, and in the kidney, 1-alpha hydroxylase will lead to 125 dihydroxyvitamin D, which is calcitriol, which is the active form of vitamin D, which is under regulation of 1-alpha hydroxylase, and also PTH indirectly stimulates 1-alpha hydroxylase to lead to hydroxylation of 25 in carbon 1 to lead to 125 dihydroxyvitamin D. This active form leads to, in the intestine, it will lead to intestinal absorption of calcium. And also in the bone, it will lead to bone resorption, which will increase in calcium and phosphorus in the blood. And also in the kidney, it will act on the distal convoluted tubules to increase the calcium absorption from the kidney. So it will lead to a normalization of calcium level in the blood when there is hypocalcemia. PTH also regulates calcium through direct and indirect mechanism. Through the direct mechanism, it will lead to bone resorption and so increase serum calcium and phosphorus in the blood, and also act in the thick ascending lobe of Henle and distal and proximal convoluted tubules. It will lead to and decrease phosphorus reabsorption, so it leads to phosphaturia, and also indirectly increase the 1-alpha hydroxylase, so will lead to 125 dihydroxyvitamin D, which will also vitamin D, will lead to increase the serum calcium. Calcitonin is a calcium lowering hormone from the parafollicular C cells in the thyroid gland. It increases bone, it decreases the bone resorption, so it decreases serum calcium when there is hypercalcemia only. The symptoms and signs of hypercalcemia, sometimes it's there is no And also in the CNS, it will lead to confusion and depression and fatigue. On the renal, it will lead to polyuria and polydipsia through nephrogenic DI and the neurocalculi and nephrocalcinosis. And in the pancreas, it leads to pancreatitis. In the heart, it leads to systolic hypertension with short ST segment. And the GIT, it leads to anorexia, nausea, vomiting, constipation, and abdominal pains. And in the bone, it leads to bone pains and fractures. So the presentations of hypercalcemia: asymptomatic accidental discovery or hypotonia, poor feeding, vomiting, constipation, abdominal pain, lethargy, failure to thrive, and polyuria or dehydration, sometimes seizures like our patient, renal failure, pancreatitis, reduced consciousness, and sometimes psychic troubles in psychiatric symptoms in adolescents. The classification, when we come to classifications of hypercalcemia, we have mild at less than 12 milligram per DL, and moderate from 12 to 14 milligram per DL, and severe for more than 14 milligram per DL. And when we are classifying hypercalcemia, we have to know if the PTH is high or the PTH is suppressed. So it's PTH dependent. So the parathyroid gland is producing a large amount of PTH, which in turn leads to hypercalcemia, while it's PTH independent, either through PTH-related peptide by cancer or excess production of 1,25-dihydroxy vitamin D. When we are coming to the pathophysiology of hypercalcemia, it's either by bone resorption from lytic lesions, like in the bone, or from cancer, or increased gastrointestinal absorption of calcium through enhanced 1,25-dihydroxy vitamin D, or secretion of calcium through the action of thiazide drugs. So we have the increased intestinal absorption of calcium through either the metabolites of vitamin D, either it's high 25-dihydroxy vitamin D or due to 1,25-dihydroxy vitamin D. If it's high 25 only and the 125 is low or normal, so it's vitamin D intoxication. And nowadays we have before we have the dose of vitamin D, 600,000 units were given intramuscular, and we know a lot of people giving intramuscular injections of vitamin D every 2 weeks or every week for 3 to 4 doses. This huge amount leads to vitamin D intoxication, and the vitamin D is deposited in the adipose tissue, and so will take a long time to be released from the body, either due to incorrect prescription or accidental overdose. The mechanism of hypercalcemia and vitamin D intoxication, the 25 bind to vitamin D receptor. And this is in the normal physiology, but in vitamin D intoxication, these vitamin D receptors will be occupied. And so the 125 free will be increased. So we have high 25-hydroxy vitamin D and normal or low 125-dihydroxy vitamin D. And the high calcium will be high, and the phosphorus will be normal or high, and the alkaline phosphatase will be normal, and there will be hypercalciuria and sometimes nephrocalcinosis and renal stones. When we are looking for high 125-dihydroxy vitamin D, it's either from idiopathic infantile hypercalcemia, granulomatous disease like sarcoidosis, tuberculosis, histoplasmosis, pneumocystis carini. All these will produce 125 from the macrophage in the granuloma malignancy like leukemia, lymphoma, and rhabdomyosarcoma, ovarian tumors, and pheochromocytoma, and also hepatic carcinoma, hepatocellular carcinoma. All these will produce parathyroid-related peptide, or in 1%, it will lead to 125 from 1-hydroxylase activity in the malignant cells. Subcutaneous fat necrosis will be released from the macrophage in the subcutaneous fat necrosis, and phosphate depletions, especially in premature babies. When we are dealing for idiopathic infantile hypercalcemia, when we have this idiopathic infantile hypercalcemia was not known, so they're given a name of idiopathic, but now we have 2 genes which will lead to infantile hypercalcemia. We have here, the first one is mutation in the CYP24A1 gene, which is producing a 24-hydroxylase enzyme, which is responsible for degradation and breakdown of 125, the active form of vitamin D. And if this mutation is present, so there will be no degradation of of 125 and will lead to increase in 125 dihydroxyvitamin D, which will lead to hypercalcemia. The other gene mutation is SLC34A1 gene, which is responsible for sodium phosphate co-transport in the kidney, which is responsible for reabsorption of phosphate. When this mutation is present, so there will be no reabsorption of phosphate from the kidney, and so there will be hypophosphatemia and hyperphosphaturia. And when the phosphate is low, this phosphate is decrease the fibroblast growth factor 23, and both phosphorus hypophosphatemia fibroblast growth factor 23 will lead to increase in CYP1 to 24A, which will lead to increase the production of 125 dihydroxy vitamin D and leads to increased hypercalcemia and suppression of the PTH. So we have two mutations in two genes responsible for idiopathic infantile hypercalcemia. The first one is responsible for the degradation of 125 to 24 hydroxylase, and the degradation will not be present, so the 125 is increased. And the other one is SLC34A1, which is responsible for sodium phosphate co-transport and will lead to hypophosphatemia. And when we replace the phosphate, the patient will move. Normal or low 125. This is either drugs in vitamin A intoxication with pseudotumor cerebri, and the vitamin E intoxication, the mechanism of hypercalcemia here will be due to increased bone resorption by osteoclastic bone resorption. The thiazide diuretics will work on the sodium chloride transporter, which will lead to decrease in the volume, urinary volume in the distal, which will lead to reabsorption of calcium, paradoxical effect, and leads to hypercalcemia, chemotherapy, endocrinopathies like hyperthyroidism and severe congenital hypothyroidism due to the inhibitory effect of TSH on osteoclastogenesis, and Addison disease and pheochromocytoma, important errors of metabolism like lactase deficiency, disaccharidase deficiency, and blue diaper syndrome, and hypophosphatemia from decreased alkaline phosphatase, non-specific alkaline phosphatase tissue, non-specific alkaline phosphatase enzyme, and lactase and disaccharidase deficiency due to the hypercalcemia here is due to metabolic acidosis and fermentation from lactose in the gut will lead to increased intestinal reabsorption. Immobilization will lead to decrease in the osteoblast formation with relative increase resorption activity. Congenital syndromes like Williams syndrome with elephant facies and hypercalcemia and subaortic stenosis, and Jensen metaphyseal chondroplasia, malignancy leading to osteolysis or PTH-related peptide secretion. When we are approaching a case of hypercalcemia with Pth dependent, so we have a hypercalcemia, so we will measure the PTH. If it is high or normal, this is apart from our scope in the literature, in the lecture, and we have a low PTH, so it is non-PTH dependent hypercalcemia. Will measure the total vitamin D, 25 hydroxy vitamin D. If it's high, so it's vitamin D intoxication on the formula. When we're having a low normal, so we will measure 125 dihydroxy vitamin D. If the 125 is high, so infantile hypercalcemia, granulomatous disease, malignancy, subcutaneous fat necrosis, and phosphate depletion. If low or normal 125, it will be vitamin intoxication, vitamin A, thiazide, chemotherapy, endocrinopathy, and inborn error of metabolism, immobilization, Williams and the Jensen metaphyseal chondrodysplasia, and malignancy, which lead to PTH-related peptide. So this, our patient here was having normal 25 hydroxy vitamin D with high 125 hydroxy vitamin D, and also fit. And unfortunately, we are not having the gene to do the gene, but it's the diagnosis is idiopathic infantile hypercalcemia. When we are dealing for treatment of hypercalcemia, first we have to stop vitamin D. We have to stop any calcium or diet. And the hydration, the best is normal saline. First, to restore the intravascular volume, and also normal saline will lead to increase the calcium excretion by promoting the urinary calcium excretion from the proximal convoluted tubules and lobe of Henle. We can also add diuretics, but take care from aggravating the volume depletion. Subcutaneous calcitonin, as it's an effective anti-resorptive agent, it's either sub-Q or intramuscular, short-lived due to tachyphylaxis. The dose is 2 to 4 units per kg every 12 hours. And we go to bisphosphonate. This anti-resorptive therapy decreases osteoclast activity. We have bamidronate and zoldronate. The zoldronate is more powerful and more effective. And we have to take care. First dose, we give a dose for zoldronate in the hospital. Patient may develop fever, bone pains, muscle pain, flu-like symptoms. So we have to take care. Also glucocorticoids, especially in 1,25 dihydroxyvitamin D mediated hypercalcemia, and it works to decrease 1-alpha hydroxylase activity, inhibit osteoclastic bone activity, and decrease the calcium absorption from the gut. And I forgot to tell you, there is a syndrome, milk alkali syndrome, which is due to increase in calcium carbonate containing acids or calcium carbonate medications, and it's having alkalosis. The clue is having an alkalosis in the blood gas. Back to our, also there is a recent modality, which is denosumab. It's a monoclonal antibody, which will bind to rancil. The rancil is a receptor activator for NFK ligand, which will inhibit the formation and function and the survival of osteoclast, and so it responsible for the bone resorption. When we are differentiating between bisphosphonate and the bisphosphonate will go to the mature activated, will go to the bone mineral and bind to the bone mineral and enter into the activated osteoclast, make apoptosis of the osteoclast. While the denosumab, it will block the rancil, and so it will lead to decreased survival, decreased function, and decrease hypercalcemia. So this is the difference in the mechanism between denosumab and bisphosphonate. It's from the reversibility of symptoms and also responsible for time of action. The denosumab is fast and the bisphosphonate work after 48 hours. Back to our case, we stop vitamin D, of course, and we stop calcium-containing medications, and we give normal saline 1.5 maintenance. We give steroid 2 milligrams per kg per day, and 1 dose of zoldronic acid with remarkable reduction of calcium to 9 milligrams per DL, and also we give phosphate in 40 milligram elemental phosphate per day. And take-home message, hypercalcemic symptoms are non-specific. The differentiation between Pth dependent and Pth independent hypercalcemia is a critical step in diagnosis. A thorough dietary history with